Coming to the hearing detection, hearing evaluation. So hearing evaluation, there are few things to note. Often this Inicet people are very fond of asking the MCQs from the hearing evaluation. So what are all the things to note? So basically, if any person is coming to you with a hearing loss, so what should you do in hearing loss? We have to do a tuning fork test. And then based on the tuning fork test clinical inference, we have to subject the patient to pure tone audiometry. Pure tone audiometry confirms whether the tuning fork test findings. So we can say whether the patient is having conductive hearing loss or sensorineural hearing loss or a mixed hearing loss. If the patient is having conductive hearing loss, we have to subject the patient into a separate pathway. Next is impedance audiometry or tympanometry to find what is the pathology in the conductive hearing loss, what is the probable pathology in the middle ear based on the impedance audiometry. If the patient is having a sensory neural pathology in pure audiometry, we have to travel in a different way. What are the two different segments of sensory neural hearing losses? Cochlear hearing loss, retrocochlear hearing loss. So whether the patient is having a cochlear hearing loss or retrocochlear hearing loss, we have to assess by means of some special test, ABLB, CC, tone decay test, speech audiometry. These are all the tests for difference between cochlear and retrocochlear hearing losses. And apart from this, two objective tests, OAE for screening and BERA for definitive test for all the neonates, infants, malingerers, mentally retarded people, objective testing. So these are all the things we have to note in this segments. So coming to the question, a 32-year-old female presents with progressive bilateral hearing loss in the right ear more than the left. Right ear more hearing loss than the left, but both are having hearing loss. After the initial evaluation, a stepidotomy of the right ear was planned for the patient. What might have been the tuning fork test results of the patient? So very simple, stepidotomy. So what is the diagnosis? Otosclerosis. What is the type of hearing loss in otosclerosis? Conductive hearing loss. The patient has bilateral conductive hearing loss, and the patient has bilateral conductive hearing loss and more hearing loss on the right side than the left side. So obviously, if there is a conductive hearing loss, very simply, what is the RINA? RINA will be negative on both sides. Bilateral RINA negative, negative. So rule out the C, rule out the D. So bilateral RINA negative, negative. So again, what happens to the Webers? Webers will be lateralized to the deaf ear, more deaf ear in a conductive hearing loss. So obviously, Weber will be lateralized to the deaf ear itself in case of conductive hearing loss. We all know that very simply. So Weber lateralized to the right ear. So that's all. So bilateral RNA is negative. Weber is lateralized to the right side is the typical inference of the tuning fork test here. So this is a picture. You make a picture and make the findings like this, and you can get the answer. So that's all. So this is about the answer here. And the next, in this question, see, they have not given the complaints of the patient at all. And they're asking with the question in a patient, RNA test positive in both ears. Again, have a diagram at least in your mind. Positive in both ears. Weber is lateralized to the right ear. Weber is lateralized to the right ear. What does this signify? Right sensory neural, left sensory neural, right conductive, left conductive. First thing, if it is a conductive deafness, RNA should be negative. RNA should be negative. So here the RNA is positive. So it is either a normal hearing or a sensory neural hearing loss. It cannot be a conductive hearing loss for the patient. So rule out right conductive, left conductive. That's all. So we have framed it as bilateral sensory neural probably or unilateral sensory neural hearing loss because RNA is positive on both ears, sensory neural or normal hearing. If the both ears are normal hearing, Weber will be heard in both ears. But here what happens? Weber is lateralized to the one ear. So Weber is lateral to the right ear here. So what is the pathology? Obviously, it should be a left sensory neural hearing loss. Because assume if the patient is having a right sensory neural hearing loss, Weber will be lateralized to the opposite ear, left side. So in conductive deafness only, Weber will be lateralized to the same deaf ear. But in sensorineural hearing loss, Weber will be lateralized to the opposite healthy, more hearing ear. So this is the Weber's inference. So here obviously since Weber is lateralized to the right ear, it is a left-sided sensorineural deafness. So this is the answer for this question. So Rinne and inferences with this tabular column, remember in a column wise, first column, second column, third column. So what are the inferences on doing the Rinne? Either the air conduction is better than bone conduction, or a bone conduction is better than air conduction. And the same two things repeats, 1 and 2. The same AC-BC, BC-AC repeats. So the first column remembering is quite easy. And second column, what is the type of test we are getting, whether it is a positive test, a negative test, false positive, false negative, right? And like in the fistula test. So very easy again, but only one point to remember, there is no inference called false positive Rinne. In Rinne, it is reduced positive, positive, negative, reduced positive, false negative Rinne. Because in third condition, both the air conduction and bone conduction are decreased. AC is better than BC, but both are decreased due to sensorineural pathology. That's why it is called reduced positive Rinne. And in the last, what are the types of hearing loss? You know, if the question has been asked, what will you say? Normal hearing, conductive hearing loss, sensorineural hearing loss, total deafness. That's all. So mark in that order. The third column remembering is over. So if you remember in this way, it's easier to crack this Rinne's test. Positive, negative, reduced positive, false negative. Normal hearing, conductive hearing loss, SN hearing loss, and then the total deafness. Very simple. So this is about the Rinne's test. Okay. The positive negative inference is very important. If Rinne is positive as given in the question, it can be either a normal hearing individual or a sensorineural hearing loss. It cannot be conductive. Very, very important. It cannot be conductive. So easily we can pick up the answer, rule out the other options. But if the question carries negative Rinne, there you have a catch. It can be a true negative, that is conductive hearing loss, or it can be a false negative Rinne, which is seen in profound or total SN hearing loss. So in the negative, we should be a little cautious. So this is about this assessment of the Rinne's test in question. Okay. So Weber is very clear. If the patient is coming to you with a diseased ear, for example, right ear, if the Weber is lateralized to the diseased ear itself, the patient is having conductive hearing loss in right ear. And if the another patient is coming to you with the right ear deaf, and in this situation, the patient is having lateralized to the normal hearing ear, then the diseased ear is having sensorineural hearing loss. So this is about the inference of the Weber. And one another tuning fork test, which we need to know many times, this has been asked in Inicet. In which of the following conditions is Gillies test is negative? CSOM with labyrinthitis, where you get sensorineural hearing loss, senile deafness, presbyocusis, sensorineural hearing loss, Meniere's, sensorineural hearing loss, otosclerosis, conductive hearing loss. So that is a one odd man out here. So Gillies test is negative in otosclerosis. We need to know what is Gillies and Qbanks test. If you use a Siegel speculum and doing the pressure changes in the extremal and observing for the hearing, that is Gillies. If you do a tragus occlusion test and observing for the hearing, that is Qbanks. That's all. These are two things, but both test bone conduction. Place a tuning fork over the bone conduction. You are increasing the pressure, releasing the pressure. On doing alternatively in the extremal it is jamming the ossicles, releasing the ossicles, jamming the ossicles and releasing the ossicles. So whenever the patient is having a normal hearing or a sensorineural hearing loss, your conductive apparatus is normal in those patients. You are jamming and releasing this ossicular system, tympano-ossicular system, and hence the patient will hear the sound with high intensity and low intensity alternatively. But if the patient is already having a conductive hearing loss, where this either the meatus or the ossicular system is already been jammed, it is not working properly, your doing the alternative increasing and decreasing pressure will not make any difference, because already it is not working. It is jammed in a conductive deafness. So your altering the pressure will not make any difference for the patient. They will not hear any increase or decrease in intensity. There is no change in intensity for the patient. So this is the inference of Gillies and Binks. So Gillies and Binks, there will be a change in intensity of the sound for the patient in case of normal hearing and SN hearing loss patient. And in a conductive hearing loss patient, there won't be any change. This is what the mnemonic I have given as a chips pocket, a bingo, nothing official or anything. Just have a mnemonic. Bing's test and Gillies test. In otosclerosis, bingo. In Bing's, in otosclerosis, no. Do you feel the bingo is very healthy for you? No, it is no healthy. You can eat occasionally, but we will say no to bingo chips. So this is for your mnemonic, that's all. So no. So in Bing's in otosclerosis, there is no change. N for negative. So Bing's test is negative in otosclerosis. Positive, change in intensity is there, that is positive. There is no change in intensity by the patient, so that is negative. So Bing's in otosclerosis, there is no change in intensity of the sound, or it is negative. So Bing's and Gillies is negative in otosclerosis or any huge conductive hearing loss patient. Coming to the Putin audiometry, of course, the symbols are quite important. Based on the symbols only, we can identify the answer, which is very common nowadays. So what is the diagnosis of this PTA chart? Very clearly, very two lines are given. What is the diagnosis of the PTA chart? So please remember to see the symbols always. And don't see the colors or the dotted lines or anything. See the symbols, that's quite important. So in this, they have given two lines, that is into marks. So into mark is the symbol for left ear air conduction, and see the symbol round. Round is the symbol for right ear air conduction. I will tell you the simple mnemonic in this, but from the question. So they have given two lines, air conduction lines. They have not given the bone conduction lines. What does it mean? It means the bone conduction should be taken as normal. It is not given, so it should be taken as normal. Nothing, there is no description of any disease or any symptoms for the patient, obviously. So bone conduction should be taken as normal. Please remember, only the air conduction sounds are given. And where are these air conduction sounds of this left ear and right ear? See, we know up to the 25 decibels. This is 20, this is 25. Till 25 decibel, if the line is placed above that, that is normal hearing range. Till 25 decibel, that is a normal hearing range for the patient. So for this patient, I told you both bone conduction and of the left and right ear is not given, it is taken as normal. We will assess for the right ear separate and the left ear separate. First, take the left ear. The left ear air conduction is already in the normal hearing range. Where is the bone conduction for this patient? That is also in the normal range. So obviously left ear the patient is having normal hearing. Simple. So this extra deviations, please don't bother. Minimal deviations can be there. The majority of them, and this audiogram mainly in the speech frequency is 500, 1000, 2000 and 4000. These range is very important in assessing the audiometric curve for getting the hearing percentage impairment. So majority is within the 25 decibel. So left ear is normal hearing. But for the right ear, what happens? The air conduction has fallen down from the normal range. Where is the bone conduction for this patient right ear? It is in the normal range. It is in the normal range. So there is obviously bone conduction is better than the air conduction in the right ear. The air conduction has fallen down. What is the gap existing between these two things? Air bone gap for the right ear is present. So air bone gap is present means that is conductive hearing loss for the right ear. So answer is right ear conductive hearing loss. So this is about the cracking this audiometry chart.